UCL. He wrote an article together with co-authors in the British Journal of BMJ soon after the publication of the EBC-TCG. So he will share with us his thoughts around this subject. Thank you, Jay.
Thank you very much. So this paper seemed to have caused quite an uproar. A whole session was dedicated to it in ABS, and I was given 3 minutes at the end to say my case. Thank you very much for offering this platform to say what I want to say in a full form. So my question is, I was a very strong supporter of neoadjuvant chemotherapy when it started long ago, but I have come to think, whom does it really benefit? So this was the paper. Now the point I want to make in this is that this paper was submitted to the BMJ in August 2017 before the publication of the EBC-TCG paper, and it was published on 11th of January. And these are the authors of the paper, and these are the key messages I hope to convince each of you about. Number one, I found that neoadjuvant chemotherapy is increasingly being used for breast cancer despite the higher rate of local recurrence, which have been shown in every meta-analysis that have been done. But perhaps because of the dramatic response rates that we see to new chemotherapy agents. And this, I believe, might be misguided. The increased pathological response rate of the primary tumor does not translate into any survival benefit, and the same drugs do not improve survival. And therefore, we must acknowledge that neoadjuvant chemotherapy probably may not benefit patients, and we should consider reducing its widespread use. So, when neoadjuvant chemotherapy was thought of, it was a fantastic idea. The first reason why it was being used was to reduce the size of the tumor so that it is operable from a place where it wasn't operable. You couldn't even do a mastectomy in these large cancers. Then we thought, well, there's going to be a bonus. We're going to start chemotherapy, which really cures patients from metastatic disease at least 6 weeks early, before the surgery is done. So therefore, it must improve survival. And what I would like to remind everybody that those trials were done with an idea to show improvement in survival. And the fact that we did find an improvement is a negative result, not just it doesn't worsen mortality. That is not an excuse. They did not improve survival, and that's a point we need to take home. That's the elephant in the room we need to recognize. Third aim was another bonus that while giving chemotherapy, you would reduce the size of the tumor and you might do a smaller operation, and to improve breast conserving surgery rate. And this secondary endpoint was what was shown to be working to some extent in the meta-analysis which shows us now. But finally, the most interesting biological reason for doing this is to have an in vitro assessment of tumor response. Just like we put infectious diseases, we take a sample of wound fluid, put it on a petri dish and see which antibiotics it works. We thought it should work for cancer as well, but probably it doesn't. So it could give clue to prognosis. Nice to know if it is good. It would change a treatment if it doesn't work. And finally, we could use it to approve or reject new drugs. So I believe at the end of this discussion, this is probably the only real valid reason to do it, and perhaps to some extent to improve breast conserving surgery rate. So neoadjuvant chemotherapy is given before surgery, and as I said, almost 30 years ago, we started this in Tata Hospital, where it was thought to be the new thing to do. That is how the modern treatment should be. And when I came to Royal Marsden in 1996, we started seeing dramatic responses to anthracycline chemotherapy, and there was a small trial, which I couldn't really find a full publication of, in which patients, I remember these patients, who had nearly complete clinical response but didn't have an operation. What we started finding is very soon, they came back with massive local recurrences. So that trial was abandoned. The first warning to me from my enthusiasm towards having neoadjuvant chemotherapy came in 2005 with this publication in the Journal of National Cancer Institute, which was the first meta-analysis of trials of neoadjuvant chemotherapy versus adjuvant chemotherapy. And those trials, what was found that, well, very sad news, it does not improve survival. Not only that, it worsens local control. And that was a 22% relative increase in local control. and increase in local recurrence. So that started worrying me about this paradigm of neoadjuvant chemotherapy. And that was a Cochrane overview, meta-analysis in 2012, which essentially came to the same conclusion. And I've been waiting for the Oxford group to do this analysis. And so my final push to write this paper came when I started seeing this. Pertuzumab is a HER2 antagonist, and it had shown a dramatic improvement in complete pathological response rate. And you can see how it goes up from 22% to 39%. And people thought, well, it is almost doubling the pathological complete response. It must be good for the patient. So this was the argument held in multiple MDTs which I attend. Firstly, because of this, it was licensed by NICE to be used in neoadjuvant setting. But it was not licensed for adjuvant therapy. The affinity trial testing it in adjuvant therapy was going on. So as neoadjuvant chemotherapy, it increased the pathological complete response rate. So for every HER2 positive case, there was a perverse argument. She will need chemotherapy anyway. So we cannot give it postoperatively. Let us get pertuzumab in her before the operation. And this is said repeatedly in every MDT and prejudging the outcome of the randomized controlled trial of its benefit. So anyone with any size of HER2 positive tumor was started receiving neoadjuvant chemotherapy. And then the results of the affinity trial were published last year in 2017. And they were published in New England Journal of Medicine, simultaneously reported at ASCO. And what did they find? They found this. Now from sitting out there, can you actually see any difference in the lines which you can see up there on the left-hand side column? The only graph which was prominently shown was that one, which showed a 1-point-something% difference with a p-value barely reaching significance, and in the outcome which is called invasive disease-free survival. I don't know what the total disease-free survival was at all. It's not reported. So I don't know why they chose invasive disease-free survival, but that is what showed a p.05. I thought that was yes. And I looked and looked and looked, and I found in the appendix, page 31 of the supplementary appendix, quite difficult to find this, overall survival, which they said there was not enough numbers to maturity for this. But if you see the end of that column there, 901 patients, in 1,800 patients had reached the 4-year mark. With that many numbers, you probably should have seen a difference in survival. There was absolutely no difference in survival. So this is a lesson for us to learn from a randomized trial. What we see there, data speaks for itself. There is no difference in survival. This was a study which was initiated by FDA and published in Lancet in 2014, where they tried to see if improvement in pathological complete response rate, which we believe logically should improve survival, does it really do that? And what they found, absolutely not. So these are two graphs which you can see on the x-axis. It is the difference in pathologically complete response rate between the addition of new drug versus no addition of new drug, randomized difference found in pathological complete response rate. And you can see people have doubling or nearly tripling of pathological complete response rate on the x-axis. But does it correlate with the survival or event-free survival? It doesn't. This line should have been a 45-degree line if there was anything in there, any signal. And it is a horizontal line. No difference at all. Secondly, then I started finding more and more studies. Pertuzumab was one. Then there was Beatrice, which was a fantastic VEGF blocker in triple-negative breast cancer. You found 28% response rate increasing to 39%. But what happened in the Beatrice trial? There was no difference in survival. And I can tell you there are 20 to 30 times more number of patients in these adjuvant therapy trials, and they are very well powered to detect a difference. They didn't find a difference. Same story with Neoalto, which is a tyrosine kinase blocker for HER2 positive patients. There was a huge improvement from 30 to 51% in pathological complete response rate, but no difference in survival, overall survival when it is tested in adjuvant setting, when actually the tumor burden is much lower. And I told you about the Neosphere trial and the affinity trial, where again, the improvement in PCR do not translate into better survival reliably. Now this is the meta-analysis which you have just heard about, and Paul has shown all the details. So in that trial, in this meta-analysis, there was an increased probability of breast conserving surgery, about 65% to 50%, about 15% improvement. Now I noticed while I was listening to you now, is that 5% of that increase had already occurred before they got the treatment. So there were 50% patients who were planned to have, 45% patients were planned to have, 50% patients were planned to have breast conserving surgery when they were randomized to have adjuvant therapy, that reduced to 45% when they actually had it. And patients who were supposed to have mastectomy increased even before they had neoadjuvant chemotherapy. So the difference of 15%, out of that 5% happened even before neoadjuvant chemotherapy was given. So maybe it's really 10%. And of course, when you report, you should report intention to treat, and that's appropriate to report it that way. But what is really true is that there is a 5.5% more increased local recurrence. And I'm surprised that this is now rounded up to 6, but rounded up to 5, when the normal routine practice is to round 5.5 to 6. So, and it is even when surgery is used, there's a 3% increase in local recurrence rate. When I remember in the Target A trial, there was a 1% increase in local recurrence, and that was called as a huge increase, and that was the reason for all the opposition for the Target A trial. And here, everybody is ready to accept a 3% increase in local recurrence. And 13% is surgeries less commonly used, and this is important. What is the aim at present of using neoadjuvant chemotherapy? The only good aim in common clinical practice is to do less surgery, to do less than what is required. And that is, what are the recurrence rates we are going to expect? They're going to be higher in the range, in the higher range rather than the lower range. And there is no effect on breast cancer mortality, which is a real sad news. So this is the graph which you have just seen. Surgery commonly used 3%, and not commonly used about 13%. And this 5.5% improvement, increase in local recurrence, is worse if less surgery is done than previously planned. And that is shown in the right-hand graph, in which you can see here, if the patient is supposed to have breast conserving surgery and have mastectomy, they have the least incidence of local recurrence. And the patients who were supposed to have a mastectomy, if that is reduced to breast conserving surgery, you have a much higher risk of local recurrence. So could neoadjuvant chemotherapy be dangerous biologically? And this is a study which came up only last year, is that neoadjuvant chemotherapy induces a host tumor response. And bone marrow-derived cells infiltrate primary tumor microenvironment and facilitate neoangiogenesis and tumor regrowth. So therefore, through this TMEM mechanism, it increases cancer cell dissemination and can induce more aggressive tumor type. And this study was initially, that paper reports the study in mice and then in human beings, in patients. So the graph at the bottom is in patients. So in patients who are receiving neoadjuvant chemotherapy, there is suggestion that that increases the chance of dissemination. And the meta-analysis is underpowered to detect a mortality difference of about 1%. And you can see that actually the mortality in neoadjuvant always remains high through the graph, but the power is not there to detect local recurrence, a mortality difference. So that's how I would put it, rather than saying there's no difference in, or no chance of detecting a survival benefit. So that difference, when you look closely, there is something there. So in real life, does it really improve breast conserving surgery? And this is a large study of 350,000 patients in the US. 16% of them had neoadjuvant chemotherapy. But what they found was that the difference in breast conserving surgery rate was only by 10%. And you can see this part of the graph. When the size is less than 3 centimeters, it increases mastectomy rates. So there's a small improvement in breast conserving surgery rate, about 10%, which is what I think would EBCT-CG results would match with. And if it is small, it actually can worsen it. And I had a patient last week in FDT where the size increased during the surgery, during the chemotherapy. Now, there is another argument that now these studies were done when the complete response rate was probably 10 or 15%. Now we have much higher pathological complete response rate, and that would certainly would improve breast conserving surgery rate. And this meta-analysis of 12,000 patients studied that. What did they find? On the x-axis, you find pathological complete response rate going up to 60% in some studies. And is there any correlation with breast conserving surgery? None at all. So the higher pathological complete response rate does not lead to increased breast conserving surgery rate. So this idea that this is going to make a difference now compared to later, no. And this data is not published, but you can see here, addition of trastuzumab compared to no trastuzumab, and that is in all the studies there, finds no improvement in breast conserving surgery rate. And the last diamond you can see is data from the authors of the Neosphere study in which they have not reported breast-conserving surgery rates. And I'm surprised why it's not. He sent me a slide of one presentation and he said we can't revisit the data because it belongs to the pharmaceutical company. And they found no difference in breast-conserving surgery rate despite the higher pathological complete response by addition of pertuzumab. So the benefit of pertuzumab to patient in terms of breast-conserving surgery rate is 0, in terms of survival is 0. Is there any justification in using it at all? Now, other point that is there is that large proportion of patients with residual disease at the end of several months with the best possible chemotherapy is this. And this is what every patient should be told, and I believe may not be, it's possible that they are not being told this. And you can look at how grade 1 or 2 or grade 1 or grade 3 ER positive tumors, between 80 to 90% of patients will have residual disease at the end of several months of chemotherapy. If they are again ER positive, even HER2 positive, you have nearly 80% patients, and with best possible chemotherapy, have residual disease. And the patients in whom every MDT suggests should have neoadjuvant chemotherapy, that is ER negative patients, whether they are HER2 positive or HER2 negative, which makes it triple negative, which makes people shudder, even in those patients, the complete pathological response doesn't go above 60%. So we have 40 to 50% of patients, nearly half of the patients, walk around with cancers in their breast for 6 months, being exposed to chemotherapy and having a large tumor volume of cells easily, in an evolutionary manner, develop resistance. And we have not had a randomized trial large enough to test the mortality difference. And this is what the patients are offered. You have, at 5 months with cancer remaining in your breast, well, it probably doesn't affect mortality. And you have another option in which you can take the cancer completely away, nearly 100% complete response within the next 2 weeks. And that's surgical oncology excision. I think patients should be given this option. And because the previous option doesn't actually improve survival in any way. Walking around for months with a cancer in the breast can be a psychological burden. And this has not even been studied in any trials. One small study of 84 patients found 41% of such patients have depression. Now, there's one more thing. We can see how the tumor responds. That is such a nice thing to know. But in 50 to 80% of patients, it's an early harbinger of poorer prognosis. So are we consenting patients to tell them, well, actually, we give you this, and we'll tell you that you're going to do really badly in the next 3 months? Do patients really want to know this? Some may not. And it is also not a guarantee that they will do badly. And it's not a guarantee that those who do well will do very well. So it is a predictor of good prognosis if it is complete pathological response. But what I find strange is that all papers of neoadjuvant chemotherapy compare those who responded versus those who did not respond. It's like saying those who are going to die will die. I mean, it is completely a circular argument. Apart from the rare clinical trials, there's almost no change in chemotherapy regime when there is lack of clinical response. And people cite the CREATE-X study. The CREATE-X trial was a trial in triple-negative breast cancer patients who received neoadjuvant chemotherapy. And patients who did not respond, who had residual disease at the end of it, were given capecitabine versus not. And they found that giving capecitabine improves survival. So this is being cited as a reason to give neoadjuvant chemotherapy, to say we can add capecitabine if they don't respond. But actually, capecitabine improves survival anyway in any triple-negative breast cancer patients. And this is a meta-analysis published last year by Natori, in which they found that giving capecitabine to normal adjuvant chemotherapy improves survival when they are triple-negative breast cancer patients. So you don't need to give neoadjuvant chemotherapy to find out that capecitabine is going to be good for you. In fact, those who respond very well might respond to capecitabine even more. So, and 20% of those who respond completely die. So you might improve their survival by giving capecitabine. So to denying them by giving neoadjuvant is probably not right anyway. Are additional MRIs and repeated clinic visits before the justifiable, before the surgery is done? Is it a valid option while waiting for BRCA gene mutation? Firstly, patients should be told that there is a high risk of local recurrence if they receive neoadjuvant chemotherapy. There's a 50% chance of residual disease. And standard treatment without genetic testing, in fact, from the POST study, does not worsen survival in any way. So it is not necessary to rush genetic testing in order to do bilateral mastectomy in such patients, which actually is quite a big thing for patients to take home and is not necessary for the treatment of their cancer. they can have it done a year later, 2 years later, or whenever they wish. So prophylactic mastectomies after cancer diagnosis does not actually, in real terms, adds to survival in single-digit figures, 5%, 6%. So it's not necessary to rush it. The other reason to give neoadjuvant chemotherapy sometimes is, well, plastic surgery is not available next week. We can give neoadjuvant and then do plastic surgery. So risks remain the same. And even reconstruction does not have any randomized evidence to support it in terms of its oncologic safety and benefits in terms of quality of life and patient satisfaction. And that is a completely different lecture anyway. So there is one more point that comes up is, because of neoadjuvant chemotherapy, we can de-escalate the amount of surgery you do in the axilla. So you give neoadjuvant chemotherapy, you clip the node which is positive and remove only that node, or do sentinel node biopsy after neoadjuvant chemotherapy, and don't do clearance if that is negative. Well, is there any evidence to support that? Axillary recurrences are really very nasty to treat and not easy, particularly when they've had previous surgery. So there is no randomized evidence for de-escalating axillary surgery. There is randomized evidence that less surgery increases local recurrence rate, at least in the breast. And axillary surgery, as I said, recurrence can be much more distressing. So fertility preservation sometimes is required for young women, and sometimes, strangely, this is put forward as a reason for giving neoadjuvant chemotherapy. Well, if fertility preservation is to be done, you can easily have an operation and then do fertility preservation before chemotherapy is done. And it takes time, so it further delays the beginning of treatment for such patients. Now, this is the point which some people argued about, that it's a difficult surgery. Now, I believe it's actually conceptually difficult surgery, not technically difficult surgery. And then somebody said that, we never put clips in those days. We put clips in patients, so it is so much better. So the clip is in the center of the tumor. It's not really always in the center. And the surgeons are technologists or technicians to remove the clip or some tissue around the clip. Even MRI can't estimate the exact extent. And I wonder why residual cancer cells magically will go around the clip. And I'll show you this. This is a cancer which is quite large, and you can see row cancer cells there, which are the crabs, and we put a clip in there. So, and you do neoadjuvant chemotherapy. Now I pause there, and that was exactly 5 seconds pause. And patients have to wait for 13 billion times that much time for the tumor to disappear in about half of them. And that is about 5 months. So if I'm told that putting a clip in the center of the tumor is the best trick in the world, and we excise that, this is clipectomy. This is not lumpectomy or wide local excision at all. What I would really like is a clip, which is a magic clip, which you put a clip in, and you wait for 5 seconds or 5 months. Most of the cancer goes away, and whatever residual cancer cells are present, they come around this magic clip. And then, maybe one of them stays out again. And then you do a wide local excision, knowing exactly where these cancer cells are, in which we have such a fantastic mechanism of finding out and visualizing the cancer cells. Then that would be proper surgical excision. Compared to when we normally do a palpable lump excision, we can feel the lump, or you can see it on ultrasound. So until that comes, I'm not convinced that what we're going to do, any surgery, is like you could just take out a clip with a vacuum. Why do an operation? So there are 2 other papers that came up in this year after the publication of the paper that even strengthened this point. So this was a risk factor for local regional recurrence after neoadjuvant chemotherapy, in which a higher risk was found, and this is known preoperatively if they're node positive, if they are more than 5 centimeters in size, and if they're ER negative. The very patients who are getting neoadjuvant chemotherapy, they have a higher risk of local recurrence. So we should tell the patients, you have a higher risk of local recurrence, you really want it. So maybe they'll say no. And the TAILOR-X study found that patients who are ER positive, HER2 negative and node negative, actually may not benefit from chemotherapy unless they have a high score, biological marker score. So they shouldn't really be given chemotherapy until you know their final staging. So that just leaves very few patients who might be suitable. So at the end of it, these were the things that neoadjuvant chemotherapy indications for it could be given. Only one of them might remain, that's the top one, and the second one might be to reduce the size of the tumor to allow more conservative but less accurate surgery with a higher risk of local recurrence. So in true sense, I think patients should be given a choice, and none of these actually stand up to evidence-based medicine rather than style-based medicine. So whom does it really benefit? I really don't know. Thank you.